All right, well, welcome everyone. Thanks for joining us. I know that there must have been something, up with the screen monitors outside. I know our session didn't make it onto the screen monitors, so hopefully people will, continue to file in. But anyways, I want to thank everyone for coming and welcome everyone to the session. My name is Roger Lee. I'm the urologic oncologist at Moffitt Cancer Center, and I'm really excited about the discussion that we're going to be putting on today amongst the panelists here, as well as with all of you, to discuss some of the pointers how we can advance research on rare GU subtypes going forward. So without further ado, I wanted to start off with a couple of introductions. So the first one is going to be by Dr. Phil Spiess from Moffitt, introducing the concept behind the Global Society of Rare GU Tumors. And then the next talk was supposed to be given by Dr. Ashish Kamat, but unfortunately his flight schedule got changed a little bit and he won't be with us, but I'll be happy to speak on his behalf. So without further ado, Phil, if you wanted to take it away.
Dr. Lee, there's no everyone is aware he's been really, I would say, beyond rising stars, I would say superstars in urothelial cancer research. And Roger has done some really great research at our institution, but it really has embraced being the chair of the genomics committee of the GSRGT, and have really done some exceptional work gathering, I would say, very talented people from across the globe, and really using really key resources that we have access to. So Jeff Ross, as some of you may know, really is a medical director at Foundation Medicine, and these are some of our other very talented colleagues, have really started looking at variant histologies, at really types of cancers where really we ultimately don't even know key signatures, genomic signatures, or other personalized type of approaches we can take in improving patient outcomes. And this is just one of several projects that Roger and his committee has really led, really looking at the genomic characterization of plasmacytoid bladder cancer, also CDH1 specific urothelial cancers, and really identifying what mutations are identified using the ample resources within Foundation Medicine and correlating it with clinical data for these patients, and really starting to give us the ultimate information we need to understand a little bit better about what are the key drivers that develop these tumors and potentially will help us target them in terms of novel agents. Some of the really great work also that's sort of being conducted is looking at, for example, TMB, tumor mutational burden high, penile squamous cell carcinoma, understanding how immunotherapies may be beneficial, understanding how we could target these, also understanding and characterizing them in both the HPV positive and negative subtypes in terms of really developing key, really understanding how we improve patient outcomes. So the society, again, was developed over 2 years ago. I'm very proud that I think we have a lot of exceptional initiatives taking place, which I think are ultimately going to improve the care of our patients moving forward. I just had a conversation earlier. There's some very exciting collaboratives going on in germ cell cancer with colleagues within the IBCG, as well as within the European consensus guidelines to try to advance the care of patients with germ cell cancers, particularly seminomas, for example, which are chemorefractory and other types of malignant transformation tumors. And similarly to that, I think we have a focus on other areas like penile, like melanoma, sarcomas. We have a group that developed in our adrenal group as well, has been quite successful in doing so. And we have our website, which has relaunched. We are currently adding content to it to improve it. And I'm very excited about this collaborative with the IBCG. I think that really is going to be the next step in working collaboratively to improve patient outcomes, particularly with these unusual histologies and variants, where we're always challenged in understanding how we should best treat them in terms of multimodal treatment. This is my contact and the GSRGT's contact information. I want to thank you very much. Again, I just want to highlight our current focus is clinical trials. Some very exciting work that Andrea Necki is leading to develop our first of many trials in the GSRGT space, and promoting it and developing as the key organization to promote trials in the rare cancer space, in patient advocacy, and in partnerships. We're always very interested in partnering with key organizations who have a similar mission in terms of improving patient advocacy, patient outcomes, and promoting best level evidence of care and education resources for patients and their families. Thanks again for your attention. I really appreciate it. And again, thank you very much to BCAN for allowing me to participate in the meeting today.
Great. Thank you so much, Phil. And, for those that didn't know, so Moffitt is actually undergoing a transition to a new surgical hospital. And Phil, serving as the surgical services director, he's kind of in charge of like all the logistics and everything else that's with the transition. So he's very busy, and we really thank you very much for the time that you allotted to be here with us through Zoom. And you do get a pass for your time limit, but I will hold the rest of the speakers to their time limits. So if I can have the slides up for the IBCG. And so we'll try to keep the introductory remarks hopefully to a minimum, because I really wanted to get everybody's input on the discussion on how to really advance the, and if we can go to Dr. Kamat's slides, please, to really understand where the key pain points are in the research having to do with rare subtypes, and how we as a group can try to move the needle and advance the field forward. That would be great. All right, so Ashish Kamat is the director of the International Bladder Cancer Group, and unfortunately couldn't be here today with us because of some travel flight changes, and asked me to give this talk on his behalf. So the International Bladder Cancer Group was originally founded in the mid-2000s. It started off with 10 members to several different members that are shown here. And its mission really is to advance the research and understanding of bladder cancer, and to also educate the general public about our research results. And so as part of that, there has been a number of key publications that were generated by the IBCG, including definitions and endpoints on BCG-unresponsive disease, intermediate risk bladder cancer, so on and so forth. We've also put on a couple of sessions at the AUA over the last couple of years, hosting debates on various points of hot points of debate on bladder cancer management, which has been a success. Recently, Ashish Shilpa Gupta and colleagues had gone on to Chile to help them really advance their bladder cancer management guidelines, and this was actually adopted by the Chilean government. And so this was also another success. And with that, in line with that, we have formed a joint commission, if you will, between the IBCG and the GSRGT to really understand the subtypes of bladder cancer, urothelial tumors. Because this is a rare disease that is the focus of research for both groups, we thought that it was very much in the interest of both groups to come together, bring in key stakeholders to really understand this disease, and also try to help move the research forward. So a couple of our missions is to identify the knowledge gaps that having to do with the biological, genomic, and clinical endpoints, to prioritize the unmet needs in terms of research, education, and clinical trials, and also to obtain funding in the future going forward to really help us understand this disease better. So with that, we'll just kind of launch into the different talks first. And what we'll do is we'll group the talks together of the similar themes, and we'll kind of leave some time in between for discussion. So the first speaker, obviously have a very distinguished panel here with me today, and I'm really glad to have you guys here for a very exciting session. So the first talk will be from Dr. Francesca Cani from the Weill Cornell School of Medicine. She is a pathologist and has done a lot of research in the pathology that having to do with rare GU tumors. And so without further ado, Dr. Cani, we'll turn it over to you.
Hi, thank you for the introduction, and thank you so much for inviting me to give this talk. I'm Francesca Cani, a GU pathologist at Weill Cornell Medicine, and so today we're going to talk about what constitutes variant histology in urothelial carcinoma. So first I want to start out by saying this used to be called variant histology. We're getting away from this terminology. There's been an update to the nomenclature, and now we are calling these subtypes of urothelial carcinoma. Again, this is in the new WHO 5th edition, which was just released last year, and this updated nomenclature has been proposed since variant is commonly used to denote genomic alterations in all sorts of tumors, and so we are terming the variant histologic patterns as subtypes now. So for the remainder of the talk, I'll be referring to these variants as subtypes, or I'll try to. I slip up sometimes too. So this is a list of the urothelial carcinoma subtypes. You have conventional urothelial carcinoma. There are urothelial carcinomas with divergent differentiation, squamous, glandular, and trophoblastic, which I'll touch on, but really I'm going to focus on the rest of the tumors in this, the rest of the patterns in this list, which are the histologic subtypes. Major change, the only changes from the 2016 fourth edition of the WHO are just some slight modifications to these subtypes, namely that large nested urothelial carcinoma is now a separate subtype from nested. Those used to be grouped. And the microcystic subtype of urothelial carcinoma now includes, we've added tubular to the name because that can have a tubular pattern as well. But aside from those, these subtypes have been the same from the prior edition. And what I really want to focus on in this talk are these subtypes: micropapillary, plasmacytoid, giant cell, sarcomatoid, and poorly differentiated. I want to draw your attention to these because these have the strongest evidence of having more aggressive behavior than conventional urothelial carcinoma. Micropapillary, plasmacytoid, and sarcomatoid are a little bit more common. Giant cell and poorly differentiated are exceptionally rare. We don't have a lot of data on those, but nonetheless, they are more aggressive. So one point I do want to bring up right away is that there's ample evidence to show that subtype histology in urothelial carcinoma is definitely underreported. In community practices, a lot of community practice pathologists don't report these. They're sort of under-recognized. And central pathology re-review does have a lot of reclassification of these tumors when reviewed by subspecialized GU pathologists. And so why does this matter? Why should we care if subtype histology is being underreported? So for non-muscle invasive bladder cancer, as you know, the NCCN guidelines, which are based on the AUA risk groups, they consider subtype histology a very high risk feature. So that affects treatment decisions, putting patients in that very high risk group. The biggest treatment decision it affects is that it does warrant at least consideration of early cystectomy for PT1 disease in patients who have these subtype histologies. And again, they specify that micropapillary, plasmacytoid, and sarcomatoid are are aggressive, and so those are the ones you really want to consider early cystectomy. And I would probably throw in giant cell and poorly differentiated into that as well. For muscle-invasive bladder cancer, subtype histology also matters, more for prognosis than for therapy, because the prognosis in urothelial carcinomas that are stage PT2 to T4 are not influenced just by pathologic stage at cystectomy, but also the presence of these aggressive subtypes. There is also some retrospective data to suggest that there's limited benefit to neoadjuvant chemotherapy, particularly in the micropapillary and sarcomatoid subtypes, but again, this is retrospective data. We haven't changed our management or have recommended not to give neoadjuvant therapy, but there is some data showing that there's not as much benefit to that. So focusing on these aggressive subtypes and what we see in pathology. So the first subtype is the micropapillary subtype, first aggressive subtype. This is composed of small clusters of tumor cells. They don't have fibrovascular cores, and they're surrounded by these lacunar spaces. Generally, you want to see multiple clusters of tumor cells within a single lacunar space. There have been studies, reproducibility studies on this, showing that that's actually the best histologic feature for diagnosis. And these are often, you do see a high rate of overexpression or amplification of HER2, which may have treatment implications in this tumor. I want to touch on interobserver variability in some of these subtypes, and there is quite a bit of interobserver variability with micropapillary subtype, because a lot of tumors, even just a conventional urothelial carcinoma, can show what we see, we call retraction artifact around the tumor, and that can really mimic micropapillary histology. So that's one source of inter-observer variability. But again, the most reproducible feature is these multiple nests of cells within one lacunar space. Move on to the plasmacytoid subtype. Showing this low power image on the right, you can see, I don't have a pointer, but the top of the image has the urothelial surface, the lamina propria below it, and then the deep muscularis propria layer at the bottom of the screen. And what you can sort of see are these blue cells kind of trickling. There's some chronic inflammation in there, and then there's this other kind of loosely cohesive group of blue cells kind of traversing the lamina propria and muscularis propria. And at higher magnification, we see lymphocytes are on the top, those dark blue cells, and then infiltrating below and through that muscle layer are these other cells that are kind of basically infiltrative and look distinct from those lymphocytes. Much higher magnification reveals that these are single infiltrating cells. They have a plasmacytoid appearance. Note they have very eccentrically placed nuclei pushed to the side, and they look very much like plasma cells. They have discohesive growth, and that means that they can spread very easily along tissue planes and peritoneal surfaces, which we think lends its aggressive behavior. These are associated with somatic mutations in CDH1 and loss of E-cadherin. So the plasmacytoid subtype does have some inter-observer variability issues that can arise, mostly because there's a variety of morphologies that can show similarly discohesive growth patterns. I've showed a variety of morphologies on the right, and they all have slightly different appearances. I'll call your attention to the picture on the bottom right on figure F. These cells have more of a rhabdoid appearance, and rhabdoid morphology in bladder cancer can also have discohesive growth, and whether that should be put under plasmacytoid, I think some pathologists might classify that as plasmacytoid, and others may consider it separate as rhabdoid. So there are some issues with agreement on this particular subtype that are, I think, still being worked out. The sarcomatoid subtype is basically urothelial carcinoma that has an appearance that's indistinguishable from sarcoma. What helps us just diagnose these is when we have a good in situ component. The image on the top left, you see a nice surface of CIS, and then below it is this spindled sarcomatoid carcinoma. Really looks indistinguishable from a sarcoma in anywhere else in the body. These sarcomatoid carcinomas, urothelial carcinomas, can have heterologous elements as well, and those should be reported. Osteosarcomas, chondrosarcomas, these actually portend even worse behavior within the sarcomatoid subtype. The giant cell and poorly differentiated subtypes, or other aggressive subtypes, these are extraordinarily rare. Giant cell subtype basically has bizarre pleomorphic giant cells. You can see a nucleus that's enormous in that photo. And the poorly differentiated subtype basically lacks morphologic features that even point to urothelial origin. So here on the bottom right, we see just a sheet of poorly differentiated epithelioid cells. And these are both highly aggressive, but again, very rare, and we don't have a lot of data about them. So I'm going to touch on the other subtypes of urothelial carcinoma and mention why they also matter, even though they don't necessarily influence prognosis. The nested and large nested subtypes, again, these have been separated as two distinct subtypes. These are composed of nests of very bland urothelial cells. They infiltrate the lamina propria, muscularis propria, and these are invasive. And the reason why these are important important subtype for pathologists to recognize is that they have a deceptively bland histology. Again, nested has smaller nests, large nested has larger nests. But the main point here is that on a very superficial bladder biopsy specimen, where you're only seeing the surface, it's going to be very difficult to distinguish this from a von Brunn's nest, which is benign, due to this bland histology and the bland cytology that you see here. So they can be very tricky in diagnosis, especially in a limited sample, and so this is why this subtype is important. These subtypes have not been shown to be independent predictors of survival when accounting for stage, but that being said, they do tend to present at higher stages. The tubular and microcystic subtypes, these are closely related to the nested subtype, and they're similar in that they have very bland, cytologically bland cells. They line tubular and microcystic descended structures, and again, similar to how the nested variants mimic von Brunn's nest, This tends to mimic cystitis cystica glandularis, which is benign. And again, the bland histology in a very limited sample can be very easily mistaken for a benign process or vice versa. The lymphoepithelial-like subtype, this is composed of sheets and clusters of undifferentiated cells. They tend to have poorly defined borders. So the tumor here is kind of the top left and the top right, and below it are these smaller bluer cells, which is the dense inflammatory infiltrate that's associated with this tumor. This subtype is important because at least data suggests that they may have a better overall survival. They do tend to be enriched for PD-L1 expression, and some data has suggested that there's some more sensitivity to chemotherapy, and there's some potential for immune checkpoint inhibitors as really good therapeutic options for these tumors, despite this sort of poorly differentiated appearance of the epithelial component here. This does tend to have a better prognosis. The lipid-rich subtype is composed of lipoblasts-like cells. So this image on the right, these look like adipocytes. And so you have these large cytoplasmic vacuoles indenting the nuclei. These are important for pathologists to recognize because this can really mimic liposarcoma. So in a metastatic site, this could be very difficult. A pathologist wouldn't automatically think of a urothelial carcinoma, but urothelial carcinoma can have this morphology in this subtype. And again, this is a pretty rare subtype. Has been associated with poor outcomes, so we might want to move that into the aggressive subtype, but there's overall very limited data about it. The clear cell glycogen-rich subtype, this terminology has been updated a little bit. Glycogen-rich has been added in parentheses to clear cell to distinguish it from a clear cell adenocarcinoma, which is different and more aggressive. This is a urothelial carcinoma that has an accumulation of glycogen in its tumor cells. Pretty rare. We don't really know much about its prognosis. And the real importance of recognizing this subtype is that it mimics clear cell renal cell carcinoma. So in a metastatic site, especially, pathologists might not be thinking about urothelial carcinoma. And even in the primary site of the bladder, you might think of a metastatic renal cell. So it's very important to realize that urothelial carcinomas can have this morphology. Just going to touch on divergent differentiation. You can have squamous, glandular, trophoblastic. Squamous differentiation, keratin pearls. In the tumor, glandular, you have glandular type epithelium infiltrating the lamina propria here. And with trophoblastic differentiation, you have these syncytial trophoblasts, big multinucleated giant cells, and they are also HCG positive. I bring these up because I just want to make the distinction that urothelial carcinoma with divergent differentiation is distinct from a pure squamous cell carcinoma of the bladder or a pure adenocarcinoma or urachal carcinoma, which does not have a conventional urothelial carcinoma component. And there are treatment implications to that. Pure squamous cell carcinomas don't usually get neoadjuvant therapy, whereas a urothelial carcinoma with squamous differentiation should be treated as such. And this, at least in the squamous and glandular differentiation, we don't really see an association with a worse prognosis accounting for stage. So another reason for subtype reporting, and I've been alluding to this, but metastases often show subtype histology, even if the original tumor had a very low percentage of the subtype. This is particularly true in the aggressive subtypes like micropapillary plasmacytoid, and you might not see a conventional urothelial carcinoma within the metastasis. So being aware of that subtype histology is helpful in diagnosing metastatic urothelial carcinoma. So if distant metastases are biopsied down the line, if you do have the subtype reporting on the primary tumor, this helps pathologists to recognize it as a metastatic urothelial carcinoma when that might not jump to mind right away, as shown by the examples I showed. So one of the biggest unresolved issues with subtypes, first of all, conventional urothelial carcinoma is often has mixed subtype histology. In fact, some of those images I showed you are actually from the same case that showed different subtypes within one tumor. It is currently recommended to report percentage of the tumor of subtype histology, but one of the issues is that there's really no standardized percentage for considering a tumor that overall classification of that subtype. For example, like top lining your report as micropapillary urothelial carcinoma, we don't have a standardized percentage for how much of the tumor should show that morphology to classify it overall. In contrast, in breast pathology, we have a very clear cutoff given by the WHO. It's greater than 90% of the tumor has to show the special type of histology like tubular or cribriform, and then it's called an invasive tubular carcinoma. But we don't really have that because we don't really have the data to show what that percentage might be. For Dr. Apollo's iconic Alliance trial looking at rare GU tumors, we are using greater than 50% subtype histology for enrollment. We felt that that was a good cutoff. At least the majority of the tumor had that subtype, because it is actually pretty rare to see urothelial carcinomas with a pure subtype histology. So take-home points. Reporting subtype histology in urothelial carcinoma is highly nuanced. Aggressive subtypes have both prognostic and therapeutic implications. The micropapillary plasmacytoid and sarcomatoid subtypes are the ones to really remember as being more aggressive. And I always advocate for central pathology review for clinical trial patients by subspecialized GU pathologists when possible, because this would really reduce inter-observer variability in issues in subtype reporting. Happy to take any questions. I think certainly if the metastasis shows like that variant at all, then yeah, or subtype. So, yeah.
One quick question. Great talk.
Yep.
I'm Steph from Dana-Farber. We know there's different, with upper tract and lower tract disease. We get very little tissue as medical oncologists. How do we account for the subtype histologies and the prevalence of upper tract or renal pelvis cancer?
I'm sorry, I missed the last part of your question.
Oh, just how, when our urologists give us for especially, upper tract and then your ureter, we know more, they're just different biologies too,
Yeah.
but we can see some of these. So how as a pathologist, how do we account when we get such little tissue
Yeah.
to say like, is there a squamous? Is there a...
It's
Yeah.
very difficult. I think on a very small biopsy, like you said, especially in the upper tract where you don't see the whole tumor, you're not going to always get this morphology on the biopsy. And so it'll be diagnosed as, urothelial carcinoma. In contrast, you might only get that subtype and you might think the whole tumor has micropapillary architecture, but, maybe it's just a small component. So that's always an issue with sampling in pathology, unfortunately, but we can only...
certain genes that are associated with them. I know we have to really help us classify.
Yeah.
Kyle Richards, University of Wisconsin. Where does the neuroendocrine fall into this subtype, or is it a separate?
So I knew someone was going to ask that. as I finished the talk, I was like, I didn't talk about neuroendocrine. One of the reasons that, so in the new WHO, neuroendocrine tumors of the GU tract have now been kind of pulled out into their own chapter. So they're like its own sort of section on neuroendocrine tumors. Prostate, bladder have all been kind of grouped into one section. You do often see neuroendocrine differentiation with conventional urothelial carcinoma, and so you could consider it a type of divergent differentiation, and certainly probably one that, definitely one that's more aggressive when there's a small cell component. But that has actually, like I said, just kind of been discussed separately in the WHO as its own, as its own kind of chapter of neuroendocrine GU tumors in general.
That's a weird decision based on that, because we see patients go in and
I
out
know.
of neuroendocrine. They'll have neuroendocrine and then they'll recur as a conventional and vice versa.
Yeah.
So that's odd.
It is
Anyway.
odd. I mean, it's still, again, would be considered aggressive, especially with a small cell component.
Yeah.
But it's
Well,
just kind
yeah.
of pulled out separately in,
Okay.
yeah.
I'm Isla Skinner from Stanford. So we're seeing more and more just on TUR specimens where a pathologist will read multiple different subtypes.
Yeah.
And what are we gonna, I don't know what to do with it today, but I really don't know what we're gonna do with it long-term in terms of figuring out prognosis and what we should pay attention to.
Yeah, I mean, I would think that the more aggressive subtypes are going to drive that prognosis. If you have an element of micropapillary or plasmacytoid, that's probably going to be what drives the tumor. We definitely see that morphology in the metastases, even when it's a small component. But yeah, I mean, like I said, a lot of the pictures I showed were from like a single case. So, thank you.
Great talk.
Thank you so much, Francis, for this excellent talk. And we will move directly to another talk exploring the rare variant subtypes in bladder cancer with Dr. Kamat Al-Ahmadi, professor of pathology at the Memorial Sloan Kettering Cancer Center, and he will give us an overview on the genomic consideration for those rare variants. Thank you.
Thank you. Good morning, everyone, and thank you for being here. First, I'll give Karima credit for saying my name correctly, Al-Ahmadi, and for those who did not know what she said, it's the same as Al-Ahmadi in general, but you feel special when someone's saying your name correct. So I'm a attending pathologist associate, and I recently took the role of scientific director of MSK Biobank, and I'll be touching upon some of the genetic aspects of variant histology or subtypes. There'll be quite a bit of overlap because you kind of start with the morphology for now, with what Dr. Kani presented, but I'll try to kind of limit that unless it's really needed. And also disclosure, I do not necessarily follow the WHO in terms when it comes to neuroendocrine. I still call them variant or like subtypes, and I use them with differentiation. I agree with everyone. The decision was not necessarily scientifically based, but we'll deal with it. And maybe with the next round, we'll probably try to revise that distinction. Just a quick look, refresher of some of the morphologic spectrum of urothelial carcinomas. And the way I like to always start with this, because just to show you, kind of have a reference point and also to highlight an important aspect, which is almost every histologic subtype starts from a urothelial precursor. And this is very important to keep in mind that these are not just tumors that develop as they are different histology from bladder. They all have precursors. And if they don't have that, then they become different subtype, like adenocarcinomas if there's no urothelial, as Dr. Kani mentioned, or squamous cell carcinoma and you don't have any urothelial precursor. And that is important because when you look at them, they're not one subtype. They're not variant histology. So when you talk about variant histology, it's important to keep in mind that these are not unique. They're not one entity. And then depending on the mechanism, how they develop, you could see tumors going from staying as a morphologic, as an epithelial tumor, but different histology, like glandular, micropapillary nested, and sometimes they lose their entire epithelial or nearly entire epithelial differentiation, such as neuroendocrine or sarcomatoid. So if you're talking about plasticity, you may be talking about kind of different type of wide categories of plasticities, things that remain within the epithelial category and things that may move into a different line of differentiation. And since all of these subtypes start as urothelial, their genetics are going to be influenced and impacted by the genetics of urothelial carcinoma NOS, which is, now we have the most evidence or more comprehensive analysis from the TCGA, which is pretty much familiar to everyone in this audience. What we know from this is the urothelial carcinoma is genetically heterogeneous as it is morphologically heterogeneous. There are different mutational processes, mutagenic signatures, different prevalence of different mutation subtypes, oncogenic pathways, and it's not uncommon. Actually, it's a more common scenario where a urothelial carcinoma can have abnormalities in a receptor tyrosine kinase and a cell cycle regulator and a chromatin remodeling gene. So all of these kind of overlap to kind of form urothelial carcinoma, and we will see, at least in the subtypes that have been studied, that this remains the case. So the genetic background of any subtype is urothelial, and then there is something additional to it. And by expression profiling, again, we have the major divide into basal luminal, and you have the subset of neuronal or neuroendocrine subtype that is enriched in neuroendocrine or small cell carcinomas. Remind you that the TCGA focused on no variant histology. There were strict criteria to include urothelial carcinoma and NOS, even though there are a few variants that kind of slipped in, especially the squamous and a few neuroendocrine carcinoma. That also left the subtypes of urothelial carcinoma out of these major sequencing efforts. There was a little bit of link to the morphologic subtype, and the subsequent consensus classification will be, the investigators start, accumulating the data that was part of the sequencing effort, and we can see some clustering or some reference. For example, micropapillary carcinoma is clustered in a subset of the luminal subtype, but other morphologic subtypes that were in the luminal, including the luminal category, were like nested, plasmacytoid, and glandular, according to some other subsequent literature, which was mostly based on immunohistochemical expression, where people wanted to kind of trim down the basal luminal categories into a few immunohistochemical markers that can be easily or more widely applied. At the same time, basal markers or basal tumors, in addition to the squamous, which is almost universally basal, we can see a subset of the sarcomatoid carcinomas are clustered into the basal subtype as well, and the other part will probably be a stroma-rich subtype, and the lymphoepithelioma-like carcinoma that Dr. Kani mentioned earlier, this also clustered in the basal subtypes. So we mentioned some of the specific variant histologies, and I'm going to show mostly two examples where we did a lot of work, and they represent two extremes. One, which is the plasmacytoid carcinoma, where since we started developing this interest, and we always likened it to lobular carcinoma of the breast, and we investigated it that way, and we found that, yes, indeed, that in that tumor is characterized by recurrent loss of some acadherin or CDH1 in the tumor. Otherwise, if you look at the background, these tumors have a very similar genetic background like urothelial carcinoma, NOS. And that finding was, important in identifying plasmacytoid histology in mixed tumors. If you have the chance to sequence both of them, as we did here, you could see that CDH1 is restricted to the plasmacytoid component, but not to the urothelial component. But these tumors in general shared alterations. And sometimes in another example, all that you need to do is acadherin stain and can nicely separate the two components for you. One point to reference to Dr. Apollo, one of the things unique about plasmacytoid carcinoma is, unlike all the other subtypes, it tends to be pure when it's present. We've seen some mixed cases, but if you have a report of really focal plasmacytoid, be careful, it may not necessarily be plasmacytoid. That could be just a poorly differentiated component from a urothelial carcinoma. So if you have the means to confirm it by acadherin loss, that'll be great. Otherwise, it's kind of suspect it first before you confirm it. It does happen, and I'm showing you these are two examples here where there is mixed, but most of the times it's nearly pure when it's present. So that was one example where a unique genetic finding can define a subset for the most cases, for now at least. Then you will see the other examples, there will be no unique genetic finding. Another subset where genomic sequencing can identify a subset is that the adenocarcinoma, when you're trying to differentiate them from glandular differentiation in urothelial carcinoma, you can see whether it's urachal or bladder adenocarcinoma, they really do not have the same genetic events that are commonly seen in urothelial carcinoma, like chromatin remodeling genes are not present, hardly any TERT promoter mutation, but they have enrichment and alterations like KRAS or SMAD4, which are typical of other pure adenocarcinomas in other organs. And how that might be helpful, this is one example. It's rare, so no one should get scared of this, but this is a case where we had a urothelial carcinoma and glandular component within the same tumor, really within a few millimeters of each other, and sometimes we were even intermixed. And the first impression was this is urothelial carcinoma with extensive glandular differentiation. When we separated the two components and sequenced them, we started first with our target panel. There were there is no overlap. No mutations were shared between the two components. And then if you look at them carefully, or individually, they followed with the typical, what we know about adenocarcinomas of the bladder, KRAS, P53, and then the urothelial component had, two alterations, TERT promoter mutation, RB, and all other alterations. Even though also the two components have P53 mutations, they were distinct. Each one has its different mutations. We wanted to confirm, we went further, we did whole exome sequencing on the both components, and still we did not find a single mutation shared between the two tumors. Again, that confirmed to us that in this rare scenario, you're not seeing a urothelial carcinoma with glandular differentiation. We're seeing two tumors here arising simultaneously within the same bladder, adenocarcinoma and urothelial carcinoma. Again, mind you that this is a rare occurrence. Most of the times you're going to be seeing urothelial with glandular differentiation. So this is going to be a part of a paper that we hope to publish soon, led by Karissa Chu and Jessica Chen at MSK. So So we'll move now to share with you some of the work that we did recently and published in collaboration with the team at UPenn, Hershey, and some other institutions as well. We studied urothelial carcinoma squamous differentiation. Just a quick reference, this, you could have it many different ways. It could be distinct geographic regions of urothelial and squamous, but other times it could be, clusters of squamous differentiation within the bulk of the tumor. We know that squamous differentiation almost always follows the basal subtype, as we can see here in the TCGA paper, where upon re-review of the cases, we were able to confirm that these were all squamous differentiation and almost all of them were in the basal subtype. But at the same time, there is a big chunk of this basal subtype that did not have any squamous differentiation. So that was why we were interested. And we went, we designed a very detailed study. We combined tumors from Memorial, from Penn State, Hershey, from Vanderbilt, and we did macro dissection, and we did whole exome and whole transcriptome sequencing on them. One thing that stood out, there was a lot of overlap between the urothelial and the squamous regions, indicating that they're all arising from the same precursor tumor, but there was no unique genetic event that could distinguish squamous from urothelial in any of the cases. So that was a little bit disappointing. But then something else also came out is that there was always higher mutation count and tumor mutation burden and new antigen load in the squamous component compared to the urothelial component, and also higher ploidy. So they're indicating that there's more genetic instability in this variant or this divergent differentiation. And when we looked at our prospectively sequenced cohort, when we looked at urothelial versus squamous cases with squamous differentiation, the genetic background, again, was very, very similar, with the exception of some alterations like P53 or CDKN2A, which were a little bit enriched in the squamous component. Otherwise, there wasn't really significant finding that could differentiate squamous from urothelial. So we knew the genetics were not necessarily the driver of subtype, so what else was there? So we relied on the transcriptome or the RNA-seq, which, as expected, all the squamous components were classified as basal, whereas the corresponding urothelial component were mostly basal, but in 4 of the 12 samples that were successful, they were more luminal subtype. Again, here when we start seeing some discrepancy. But when we looked at these bare samples, every time we looked at the urothelial and squamous component, even though they were both basal by bulk clustering, we could always see that squamous component from the same tumor has more basal signature and lower luminal signature, and the other way around was the same. A urothelial component has higher luminal signature and lower basal signature. And no surprise, when we looked, separated them by histology, they were 2 distinct groups. There were many differentially expressed genes they're mostly pointed towards skin development and squamous differentiation in other organs. But when we looked also at the individual genes, we were able to find that some of these powerful transcription factors that are involved in maintaining urothelial identity and differentiation were the ones that were almost always downregulated between the urothelial and the squamous component, namely here FOXA1, GATA3, and PPR gamma. And then to kind of delve a little bit into more details about this entity, we had a case that we're able to get single cell RNA sequencing. And when we did that, this case had extensive squamous differentiation, and you can see the H&E image. But then by single cell, we were able to find different distinct cell clusters that recapitulated the findings of normal skin development. As if I show you some examples here, a cluster that was enriched with CK5 that is typically present in the basal cell layer of the normal skin. Another cluster had these spinous cells, the suprabasal skin layer that was enriched with these like genes that are involved in making the desmosomes, desmocollins and desmoglein. And then the bulk of the cells were cells that have keratinocytes in transition or reactive keratinocytes. And then, interestingly, even despite the fact that this was extensively squamous, there were some cells showing low expression of FOXA1, can probably keeping their luminal or urothelial memory in them, but they were still at a lower expression level. So how significant that was when we were looking at this, we had Also had access to samples from a clinical trial in which patients received a single agent, atezolizumab, locally advanced urothelial carcinoma. We didn't have access to the tissue, but we were able to review the slides, and we found that from the 9 of the 26 patients who derived benefit from the treatment had lack of tumor heterogeneity. So the tumors were more uniform, while the tumors that the patients who did not benefit had more heterogeneity in their tumors, and that was reflected on also the immune subtypes that were different between the urothelial and the squamous component. And by immune cell deconvolution analysis, also there were significant differences in the type of immune cell infiltrate between the urothelial and the squamous components of the same tumor, and that was also highlighted by the PD-L1 expression. So the conclusion was that as much as you would like to say urothelial and squamous are two distinct entities and there is like abrupt change from one to the other, in reality there is always a transition, and depending where the tumor falls, you may be easily urothelial or squamous. I think I should speed up a little bit, okay. Okay. So neuroendocrine carcinoma was mentioned from the audience, and I agree that this is a unique tumor. It's still urothelial. The best outcome is when you have a localized tumor that you can treat with chemotherapy. Genetically, again, we had some work done, and then other groups have done the same. There's no unique genetic event that can dictate the development of urothelial carcinoma. The genetic background here is very similar to urothelial carcinoma and is different from small cell carcinoma of the lung, for example. And then now we have more information about them, how there are some major transcription factors that can govern the transition from urothelial to neuronal subtypes, and these transcription factors, ASCL1, UroD1, and BAUTO-F3, define a unique subsets of urothelial carcinomas with different levels of expression of neuroendocrine markers. Micropapillary carcinoma was mentioned. It's enriched with activating mutations on HER2, but also amplification of HER2 as well. One thing that is unique about this subtype is that HER2 amplification and overexpression can be very heterogeneous, and most of the times it will be restricted to the micropapillary component, not to the urothelial component. But sometimes it can be in both. We've noticed in our analysis in that even when you have mixed tumors, the NOS component in these tumors can have higher rate of HER2 amplification compared to newcomers and urothelial carcinomas NOS. So these are difficulties that were mentioned. Again, we lack standardized diagnostic criteria. There's lack of awareness in the community, and that will always impact any genomic study. If you don't have strong diagnostic criteria in the H&E, because this is how you select these cases, your genetic findings are not going to be very clean. And this is a major hindrance for studying these subtypes. Again, this is the paper that was referred to. This is a reference to some of these mixed cases. What do you do with them? That's really challenging. Again, I bring back this figure, because if you have a tumor here or here, it's easy to call it squamous and urothelial. But if it's here, depending on what your preferences and what your criteria are, you may call it urothelial or squamous. This is another example where this could easily be called plasmacytoid carcinoma, while in reality it is not, despite the absence of e-cadherin, because this tumor is bordering into a sarcomatoid carcinoma. Rhabdoid morphology, because it doesn't even have keratin, it cannot be carcinoma in the sense. So this is one when the morphology may deceive you. The same thing, an example here, this could easily be urothelial carcinoma or urothelial with glandular differentiation, but if you do synaptophysin, you'll find that this is actually a large cell neuroendocrine carcinoma, and this tumor can fall into the neuronal subtype, while the pathology report may call this urothelial carcinoma. So always one should be aware of this. Intratumor heterogeneity is very significant problem with urothelial carcinoma. A paper from our friends at Penn State showed that depending on what part of the tumor you characterize or investigate, you may find a different subtype. So it's always important to know what part of the tumor was sent for any further molecular analysis. And this highlights this slide, my last slide before the conclusion, highlights the real problem. This is within a few millimeters of each other. You can have 3 or 4 morphologic subtypes within the same tumor. So this is my summary. These entities remain challenging. They're heterogeneous. There's lack of criteria. There's no definitive pathognomonic findings. And then there's still a lot of room to study these entities. Thank you.
Fantastic talk. Thank you so much. I didn't want to cut you off because it was so
I realized
content, but I had to do it. So we'll take some time now for some discussion because obviously the two talks were just so rich in content. I'll start off with one. If nobody's obviously come up to the mic. So given like the heterogeneity that we're seeing both from the histologic perspective and also the genomic perspective, and also the constraint that we have both financially and also time-wise, pathologists not going to be able to dedicate like 12 hours a day looking at slides or running through genomic sequencing. So from the research perspective, how do you foresee, like, how should we go about, understanding this disease? And then also from the clinical perspective, you can just, speak to us, like, given what we have today, what are you going to do about, characterizing the percentages? Should we use genomic sequencing as an adjunct to the histology reports?
Yeah, I mean, great question, loaded question. I don't know if I can answer very. I don't know. I'm happy to.
You can answer it.
Either.
Yeah, I mean, I think there is no replacement for having everyone involved in the process. It's one thing to be practical and have like real world, approach, but you have to have the expertise there. You have to really be able to review. Pathologists are always happy to be part of the process. Hopefully, in the beginning of the process, where then you can plan better when you have input from the pathology rather than just come at the end. And we have to invest in the beginning. And I know there is always the hurry to get things done, the urgency, because there are patients waiting. But unless you do things right, we'll always continue to do the same mistake and not learn much. That's my opinion. I don't know if
My question's actually similar, but more specific to plasmacytoid. Do you define plasmacytoid as having E-cadherin loss? Is that like definitionally for you? This is something we struggle with. Sometimes we see like morphology that's really just plasmacytoid, E-cadherin, it's positive, but it really looks like it's behaving like,
it's for the most part, it's one of those kind of the cleanest subtypes where you have a genetic event, you have an IHC that corresponds. I agree with you. There are some cases where they look perfect for plasmacytoid, they have E-cadherin retention. That could be explained by one of two things. One could be an expression but not functional. It could be like a missense mutation, still the gene is not functioning, but the expression is there. Another thing is I'm sure there will be at some point another gene that phenocopies E-cadherin, but we just don't know it yet. Fortunately, these are rare, but we do get these cases, we struggle with them. If the morphology is perfect, the way it's growing, it's like the entire tumor looks the same, we would still call it plasmacytoid.
Thanks.
Yeah.
So this is Omar Al-Halabi from MD Anderson in Houston, and I wanted to just highlight, or at least sort of ask a question on the previous talk. It was highlighted that when patients relapse with metastatic disease, it tends to be the variant or the subtype that comes back, and we did a study that we submitted to SUO as sort of looking at patients who relapse with small cell or neuroendocrine carcinoma after having localized upper tract or lower tract bladder cancer, 60 patients. It's changes. I mean, sometimes the relapsing biopsy shows small cell, but sometimes it's a mixed bag of things. And at cystectomy, the 3 time points between TUR, cystectomy, and then the metastasis. At cystectomy, we found basically no patients that had pure small cell. It always was urothelial plus small cell. But in the metastatic setting, you do see purity or isolated small cell. And I don't know, from the origin theory that all of this is obviously one origin, urothelial origin. But when it comes to treatment decisions, would you always recommend biopsying the metastatic site? And what if there's multiple metastatic sites? Because these might have different responses to our systemic therapies, right?
Yeah, I agree. If you actually want to start? Yeah.
Yeah, I mean, I just think that's one of the challenges for sure. You're never going to know exactly what's in every metastatic site, even if you biopsy them, because you're still just getting a small sample. But I mean, I guess you have to sort of treat on what you see. If you have a biopsy that has small cell in it, then you could consider those treatment regimens.
Yeah, I mean, if I want to add, yes, I agree. And the thing is, we don't really know yet what metastasizes, to be honest with you. The study that was referenced is a great study, but it's a small number of cases. If you look at them, they're like, like a couple of dozen, cases.
Yeah.
We're doing this analysis. It's not out yet. We re-reviewed our cystectomies. We have like more than 1,500 cystectomies that we re-reviewed. There are some variants that very enriched in the metastasis. Micropapillary is one, plasmacytoid, small cell. If you have a small cell, mixed small cell and urothelial, it's very rare to have the urothelial metastasizing. It's almost always the small cell. But we have many cases where the metastasis is mixed. So, like you can easily have a squamous and urothelial in the lymph nodes, urothelial and glandular in the lymph node. So unless we do that, we have that work out there, it will still be all over the place.
Yeah.
And then you can think about it that a tumor continues to evolve after it metastasizes. It could be two clones coming from two different parts of the tumor happen to metastasize to the same area, or they could be metastasizing at different times. At one continuous seeding. One time one part went, another time another component went, and they just happen to kind of latch into the same lymph node.
Yeah.
There's still a lot of biology questions to be addressed, but at least that kind of background, prevalence of what is in the metastasis, we don't necessarily know it yet.
Yeah. And I have to give credit to Dr. Charles Gould, who our pathology lead, helping me understand all these differences. And along the same lines, sometimes we see a biopsy that stains positive for chromogranin or synaptophysin, but doesn't have the small cell appearance, that neuroendocrine. But the IHC is compatible, and then I see it frequently. The pathologist will say, maybe this is neuroendocrine, but it's only IHC.
So in our traditional approach is that you don't diagnose the IHC. That's the thing.
Yeah.
But sometimes you can't ignore it. If there is extensive neuroendocrine markers, you probably have to refer to it as some neuroendocrine carcinoma. I don't know, Francesca, what do you think?
Yeah, I agree. I think the morphology sort of for us is the thing that triumphs the IHC. So if it doesn't really have a neuroendocrine look,
But
But I'm gonna be the devil's advocate because we just showed a slide where if the CDH1 IHC is not there, we changed that. I mean, I don't know how to say it, but because when we plan the new adjuvant regimens, we have to kind of use these decisions because we pick different regimens, right?
So I can tell you my approach with this. We have it's like you can't help. You have to follow criteria, right? And you have to follow systems. But at the same time, my mentor used to say, like, use your physician sense now. You have to make a decision at some point. And if it meant just kind of ignoring a classification and call something a different name, it will have to be. Because, at the end, you're physician facing a patient, we're physicians facing, a tumor, we have to understand it.
Yeah.
So we now recognize the large cell variant of small cell or neuroendocrine carcinoma. The lung people have done it for a long time. We have, a nice cohort now we're about to publish. There are some cases where they don't give you any clue that they are neuroendocrine, but they have extensive neuroendocrine differentiation, and by IHC and also by RNA-seq that they cluster with the neuronal subtype. You can use other criteria, like if you do a Ki67, and if a tumor doesn't look like neuroendocrine, but has 90% Ki67 expression, that's probably very close to being neuroendocrine, even though it doesn't look like a small cell carcinoma.
Yeah.
So we may use a different terminology just to alert, our clinical colleagues that
Makes sense.
this tumor probably deserves a little bit more attention.
Yeah. Thank you.
All right, well, so unfortunately,
Not Dave.
it's because your partner over here took up so much of the questions.
No worries.
We will have some questions, time at the end. But fantastic talk. Thank you so much.
Thank you.
So next, we'll kind of shift gears a little bit and talk a little bit about the challenges in clinical trials in this space. And obviously, given the rarity of the disease space, it'll be very difficult to accrue patients. And we have, fortunately, with us not only our speakers, but Dr. Andrea Paulo is standing back there too, who are very expert. But first, we'll turn it over to Dr. Rafee Talukder, who just recently started at Baylor College of Medicine. He's as an assistant professor in GU Medical Oncology after finishing his fellowship in University of Washington, and he'll give us a talk on the pilot single-arm trial with sacituzumab in the neoadjuvant setting for patients with non-urothelial muscle-invasive bladder cancer.
Thank you. Dr. Apollo, if I mess anything up, just stop me. Yes, I'm not an expert, and I officially don't start my assistant professor job until Monday. So that's a caveat. Yes, essentially, I'll just talk about, kind of the clinical trial landscape in patients with non-urothelial histologic subtypes in the neoadjuvant setting. So, as you guys know, currently standard of care platinum-based chemotherapy regimens don't work as well with, a lot of these aggressive subtypes. If there's retrospective studies with plasmacytoid, micropapillary, sarcomatoid, their PCR rates, pathologic complete response rates in, 15, 20%, which is less than what we see with the pure urothelial carcinomas. So, this is definitely an area of unmet need, and we need more trials in this space. So as you guys know, there's been a lot of immune checkpoint inhibitor trials in the muscle invasive setting, the Advocacy with the atezolizumab, the Nabucco with Ipi/Nivo. I'm sure, a lot of you guys are either the PIs or involved in any of these trials. But I just wanted to highlight this because all but one of these trials allowed or included patients that either had pure or predominant histologic subtypes. And one thing I'm trying really hard not to say the word variant, so do my best. So essentially, the Pure-01, which was a phase 2 study looking at single agent pembrolizumab in patients with muscle invasive bladder cancer with. So initially, they did exclude patients that had predominant non-UC histology, but they later allowed it. Essentially, people got 3 cycles of pembro and then went to cystectomy. And if you kind of tease out the data more, kind of looking at the predominant histologic variant population, out of 114, 19 had either pure or predominant histologic subtypes. The most common one was squamous cell, followed by nested, and then micropapillary. There were some sarcomatoid, and there were some mixed ones in there as well. But if you look at the PT0N0 rate, about 16%, so out of 3 out of 19 patients in this subset analysis with histologic subtype had a PCR, whereas in patients with purity, it was, more like the standard number of 40%. So based on this, Ali Kaki, who's here in Petrus Grievous, they opened a trial at UW utilizing pembrolizumab with MVAC chemotherapy for for these patients with non-urothelial histologies. This trial is ongoing. It's a pilot single-arm study. These patients have to be cisplatin. They have to be allowed to get cisplatin. We allow N1 disease if it's contained in the true pelvis, and they have to be a candidate for radical cystectomy, and they either have to have predominant or pure non-urothelial histology, and we excluded pure small cells from this. So they essentially get maximal TUBRT, and then they get 4 cycles of MVAC, and then 3 cycles of the pembrolizumab, followed by radical cystectomy. The primary endpoint is PCR rate, and then we're also looking at secondary endpoints for toxicity, and then survival outcomes or recurrence-free outcomes that we're doing translational and correlative studies with this. So this is a pilot study. Goal is for 18 patients. We have 14 so far. I talked to Petros this morning. He told me I'm not allowed to say the numbers, but it looks pretty promising. So every time I give a speech about this, I have to ask him, can I at least give some preliminary numbers? He's like, no, not until it's close. So the data looks promising with this. And then I kind of wanted to highlight a couple of other trials. Dr. Hoffman and Dr. Cates and John Hopkins has a trial utilizing atezo with platinum chemotherapy and etoposide in patients with small cell neuroendocrine bladder cancer. This trial is currently still ongoing. And essentially it's they get etoposide as cisplatin plus atezolizumab for 4 cycles. And then Dr. Kaki and Dr. Srinivas in Stanford had a nice small trial using durvalumab in combination with platinum-based neoadjuvant chemotherapy, cisplatin or carboplatin was allowed. This was a small study, about 6 patients completed treatment. The primary outcome was just safety and tolerability. Most of the patients did go to radical cystectomy. One of the patients had a pathologic complete response rate, and in this trial, 3 patients got Toast-SMBAC and 3 patients got CarboGem. And then I just kind of wanted to shift towards antibody drug conjugates. As you know, sacituzumab is approved in the metastatic settings, as well as enfortumab vedotin and now enfortumab vedotin plus pembrolizumab. So we kind of wanted to bring this into the neoadjuvant setting. And according to the TCGA CHOP2 data, the numbers are small, but if you look at some of the non-UC histologic subtypes, they do have some expression. And then Dr. Fedgali, Dr. Wright, and team at UW did recently publish some data looking at differential expression between membrane and cytoplasmic CHOP2, CHOP2 staining, with urothelial and some of these histologic subtypes, and they seem to be pretty similar. So based on this, we created the trial just using sacituzumab in these patients that are cisplatin in not candidates for cisplatin. So we have one with MVAC and Pembro for patients that are cisplatin that can get cisplatin, and then sacituzumab. Essentially, they get 3 cycles of sacituzumab and go on to radical cystectomy, and the endpoints are very similar. Pathologic complete response rate is the primary endpoint. We just opened this trial in the beginning of the year, and we have 1 patient so far. And then lastly, I just wanted to quickly highlight Nectin-4, because as you know, EV is approved in the metastatic setting, and EV staining shows similar patterns to CHOP2, compared to urothelial. According to the TCGA database, there is some expression. And then Dr. Hoffman and her team did publish showing variable Nectin-4 protein expression among the different subtypes. So based on this, we're working on ISR, looking at EV and Pembro in this setting. I don't have the schema because we're still undergoing some modifications. So essentially, the point of my talk is, this is an area of unmet need. All of these trials are just single center pilot trials, and we're kind of lumping all of these subtypes together. So we definitely need more bigger, larger trials, multi-institutional trials, international trials. We need central pathology review, and I think we need novel treatments in this space. I think antibody drug conjugates is a good first step, but I think we need to find other novel treatments. That's all.
Okay, if you allow us, so we can move forward to the next talk and keep the question for both talks until the end. Thank you. So we will move to the other talk. Will be given by Dr. Samuel Fenn, medical oncologist from the Memorial Sloan Kettering Cancer Center in New York, and to talk about the clinical trials and the metastatic setting.
So I'll just go into my intro while they're bringing up the slides. My name is Sam Font. I'm a medical oncologist at Memorial Sloan Kettering Cancer Center in New York, and I'm very, very grateful to the organizers for the opportunity to speak, and thank you all for your attention. This is very well attended. It's great to see everybody. These are my disclosures. So this is a little bit of background. So I think we've really covered this well in terms of the subtypes and the poor prognosis associated with them. And also kind of looking at the trials that we've seen, a number of trials over the past decade, looking at immune checkpoint blockade in particular, with really limited data on how the subtypes do with immune checkpoint blockade. And so I actually kind of did the work and looked back at a lot of our major trials and went back to the trials themselves, the protocols themselves, and looked at the inclusion criteria. And you could see, these are kind of our, again, I'm not going to cover all of the trials, but you can see that the vast majority of them require predominant urothelial NOS histology. There are several trials that don't specify that it needs to be a predominant component, but overall, that's really the overriding theme here. Now, you would think, if looking at all of these major trials, many of them phase 3 randomized trials, that there would be a wealth of data on the subtypes and how they do with immune checkpoint blockade. But if we actually look from the primary publications, I'm not talking about follow-up publications, but if we actually look at the primary publications from all of these industry-sponsored studies, we really only have data from EV302. And EV302 gives us the breakdown in terms of how many patients had mixed histology in the EV group versus the chemo group. It kind of specifies a little bit in terms of the histology, but we really have no data on how these subtypes do and how they've done in the trials. And I would love to hear from others if they know of data. But in my mind, these are thousands of patients. They're clearly, the vast majority of them are not urothelial NOS, many mixed histologies, and we don't know. So I'm just going to kind of throw out there that this is a little bit of a missed opportunity, and maybe there should be a question mark after that, because I think there's an opportunity to look at these thousands of patients and see potentially how they did in our big trials. So we can return to that. So this is a trial that I was invited to discuss. This was our investigator-sponsored study. This was published a number of years back in Cancer Medicine. And I'm going to give a kind of a little bit of a behind the scenes, under the hood look at this trial, this small trial, and how it was designed. So this is a slide I kind of hesitated to include, but I think we all start with a wish list when we design a trial, and we go to industry and our colleagues in industry and with ideas, and there's ultimately kind of a back and forth and a negotiation about where we end up. So in terms of our study, and this was written in 2017 when I was a new attending. In terms of what we wanted dual immune checkpoint blockade for really no other reason than we thought that this would maximize response rates based on the melanoma data that we had at the time. We've since had a lot of data on CTLA-4 inhibition, but again, back in 2017, we wanted a dual immune checkpoint blockade. These are aggressive subtypes. We wanted to take an aggressive approach, and indeed we did get dual immune checkpoint blockade in durvalumab and tremelimumab. We wanted to do a multi-center investigator-sponsored study. Ultimately, we got a single-center IST. I think we all know how we see the budget for these trials balloon when we try and bring in other centers. That requires a lot of logistical support, a lot of multi-center support. So ultimately, we ended up doing a single-center IST. We wanted to do research biopsies on our study. We've discussed kind of the primary versus the MET. It would have been great to have known what was in the MET. Ultimately, we ended up relying on archival tissue. We wanted to design a study where each histology was its own Simon two-stage design with an overall response primary endpoint. So we would enroll a squamous, a small cell, and an adeno, each as its own Simon two-stage design to kind of flush out if there was a promising path forward there. Ultimately, what we ended up was with one Simon two-stage, grouping all of histologies, whatever would come in the door, we would put them on the trial. And so you could see kind of the number of patients that we wanted, 81 patients. The number of patients that we ended up with was 27. Now, I don't want to say that I wasn't grateful to our industry partners for the trial. I mean, I was and I am still incredibly grateful for the opportunity to have done this trial. But I did want to kind of disclose this because this is not something that's frequently talked about in terms of a wish list and ultimately what we end up with. So the primary objective was, again, to look at durvalumab and tremelimumab in patients with non-urothelial histology, overall response primary endpoint. So just to kind of look a little bit at the inclusion criteria for the trial, because I think there is heterogeneity in the way that these trials are done, and it's important, I think, to look at the details. So we were looking at small cell, squamous cell, and adeno of anywhere in the urinary tract, and then we specified that patients with squamous cell carcinoma or adenocarcinoma had to have a predominant squamous or adeno component, because again, these were patients that were excluded from the other trials. And then we did say that if you have any element of small cell or neuroendocrine, then patients fall into that group. And we did specify that for patients to go on the trial with small cell, they had to have progressed after prior, typically platinum and etoposide. So those are just kind of 2 points, and we could kind of return to discuss those in a minute. Typical exclusion criteria. So let's look at the results for our trial. So we treated 13 patients. We accrued about 1 patient per month, which is what we expected. It took a little over, a year to do the trial. The median age was typically a little bit younger than what we see with patients with metastatic urothelial in the trials, and I think that's typical of many of our subtypes, that these are younger patients. And then in terms of the histologies that we treated 7 patients with small cell neuroendocrine. 5 of them were pure, 2 of them were mixed. We treated 3 patients with squamous, 1 pure, 2 mixed predominant, and 3 adenos, 2 urachal, and 1 bladder. So this is, what came in the door. And so it was, I think, overall kind of a poor prognosis patient population. 11 out of the 13 had visceral mets, and we know that these patients typically do worse. A little over half had liver mets, which again, we know is a poor prognostic indicator. And the vast majority were pretreated with prior platinum-based chemo, even though we didn't require that for the squamous and adenohistologies. 11 out of 13 ended up having platinum. So this is how patients did. We had 0 out of 13 responders. So we did not hit the required number of responders to go on to the second Simon stage. Just to look at this kind of swimmer's plot there, you could look at the second patient down. That was a patient with small cell. And the patient progressed early with a new liver met that was ablated. And the patient continued on durvalumab and completed the full year of treatment and actually did quite well. We did genomics on the study. I'll just say that 1 patient with small cell that did the best happened to have the highest TMB of 13.2 mutations per megabase, was PD-L1 negative. So that patient did do well, but again, unfortunately didn't count as a responder. These are the PFS plots and the OS plots from the trial. You could see kind of a very poor prognosis patient population that we enrolled. So the conclusions from our kind of very small study was that this kind of very small, poor prognosis cohort of patients with non-UC, no responses were seen with durvalumab and tremelimumab. I think we all know that we need novel therapeutic strategies. So now this is kind of the part of the talk where I'm going to reflect a little bit and kind of review some of the data. I think it's great following Rafee, who discussed data in the neoadjuvant muscle invasive space. So I'm going to kind of discuss some data in the metastatic space. So this is the data that's been reported. This is Andrea's data from Iconic, and she was kind enough to provide me with some slides. So this was a study where she did Cabo-Nivo, and there's also some Cabo-Nivo and IPI patients that were treated in the phase 1 study. And she did see responses, kind of looking at the same histologies in terms of 15 urachal and adeno patients that she treated. There was an overall response rate of 20%. She also saw responses in the squamous, 7 patients with squamous histology with a very high overall response rate of 85.7. And then there were 3 patients with small cell that were treated, and 1 of them was a responder. So there clearly are responses. We just didn't see any in our study. This is a study that Bradley McGregor led out of Dana-Farber Cancer Institute. And this was part of a larger kind of not only the variants, but other, I think it included some of the non-clear cell histologies, and it was kind of a large basket trial. But at ASCO in 2019, he provided specifically the subtype bladder data. And his trial was IPI-Nivo, Nivo 3, IPI-1 every 3 weeks. And he also saw some responses in the small number of patients that he treated. 1 out of the 4 adenos, 1 out of the 4 urachals, 2 out of the 6 squamous cell, 2 out of the 3 small cells responded. And then he also saw the 1 out of 1 plasmacytide respond with an overall response rate of 37% if you include all of his variants. This is the SOL study. So this was actually a safety study done with Atezo, kind of a large phase 3B expanded study. This study accrued a huge number of patients, 997 patients that received atezo at 37 countries worldwide. This was led by Cora Sternberg, and they included patients that weren't traditionally included in the other kind of registration trials. These were kind of non-registration patients with poor ECOG, with some kind of well-controlled autoimmune disease. And just to focus on the variant data, 47 or 4.7% had variant or mixed histology. You could see the histologies here. We don't have response rates per subtype, but we see an overall response rate of 9%, so a bit low. This is the STRONG study, very similar idea as the SOL study, but with durvalumab instead of atezolizumab. A large number of patients were treated. 8% had mixed histology. And all we have really from this study led by Guru was that the non-urothelial patients seemed to do as well in terms of OS as the urothelial patients. So kind of limited, very high level data, not granular data. So what additional data is coming in the metastatic space for the subtypes? So just to highlight and give a huge shout out to Andrea, who's in the audience, for the ICONIC study. We're all waiting for these data. This is a very well designed study in terms of each histology on its own and looking for response rates, squamous small cell adenoid. There's a plasmacytoid and sarcomatoid cohorts as well. So this is a really highly anticipated and important study. There's also the DART study, or the SWOG 1609 study, that was a large kind of BMS multi-cohort study of ipi/nivo. So we have a number of publications from these studies in different diseases, metaplastic breast cancer. There was one in angiosarcoma. There was one in high-grade neuroendocrine neoplasms, not of the urinary tract, but of other sites. Another one in non-pancreatic neuroendocrine. So we're waiting on the bladder cancer with variant histology data. I am not aware of any yet. Please correct me if I'm wrong, but I couldn't find this data yet, and I think it's to come. This is another small study out of UCLA in the metastatic space for neuroendocrine of the urinary tract or prostate. With Pembro, with etoposide and platinum, that seems to have completed accrual. It took 4 years to complete the study, and we're waiting on data. So what are the important directions? Where do we go from here? What are the important questions? What should we be thinking about when we're thinking about the subtypes and moving the needle forward? So let's look actually at the NCCN guidelines. My slide got messed up. So this is where we are. And I think if you look at the NCCN guidelines for bladder, they've evolved tremendously over the last 10 years, but this is pretty much the same slide, as it was 10 years ago. We really don't have really that much improvement. For the mixed histologies, because they were included in the trial, we treat them like pure urothelial NOS. We don't know really how they do. We are in desperate need of clinical data. For the pure squamous patients, we're left with very limited options in the NCCN, really, in terms of combination chemo, Taxol, IFOS, CIS. We're really left with quite little. For the pure adenos, same thing. We kind of extrapolate from the treatment of patients with adeno GI tract cancers with FOLFOX and other regimens with really very, very limited data. Now for small cell, they've said you could treat it like small cell of the lung. Which I think actually gives us a lot of latitude to extrapolate from those patients. And I think many of us are already treating them with combination etoposide platinum and either durva or atezo based on the small cell lung cancer data. So we do have some latitude there. I would just say, I think we've all gone, those of us who treat patients with variant histologies, particularly the pure squamous and pure adenos, have been on the phone with payers trying to get immune checkpoint blockade approved, but have had a difficult time because, again, we don't have NCCN guidance there. And I would think, particularly for the pure adenos, maybe we should have some more latitude in extrapolating from colon cancer, like we do for small cell of the lung. And maybe we should kind of be referring to the NCCN guidelines for colon, because I think that's what many of us are trying to do in practice. So just as one, another question, should we be doing industry-sponsored studies or should we be doing ISTs? And this is one example from non-clear cell RCC that I think is quite important to note. So the industry-sponsored study, Keynote B61, kind of shows the power of industry. 41 centers, 14 countries. They, in less than a year, they enrolled 158 patients with non-clear cell RCC. It was just published in Lancet Oncology, and I think will ultimately make it into the NCCN. I don't want to kind of, this is not to badmouth the investigators doing a very similar IST in the same patient population with the same agents, but just shows the difficulty of doing an IST. This study started initially as 1 center in the US, it's now 4. It started in July of 2020, and it's still ongoing, and they're looking only to enroll 34 patients, and we don't know when that will be published. So that really just shows the power of industry. If they want to get something done, they get it done, and I think it's stark. And so, what really is the direction there? So, this is what I call. So, this is a target-based approach, in treatment of of our subtypes, and or you could also refer to this as the piggyback approach. So this is just one example of the study, particularly for our neuroendocrine or small cell patients. There's a promising therapeutic target in that patient population called DLL3. And I think a number of companies are targeting that. This is one example of a study which we have open. And it's a study really designed for small cell cancer of the lung. Because that's a much more common disease. But they're also allowing, if you look at bullet points 2 and 3, patients with neuroendocrine or small cell histologies that start in other organs. So we could actually get our small cell bladder patients or our small cell urinary tract patients on this trial, and to kind of use the slang, there's no shame in that game, so to speak. I think that as long as we could get our patients on trials, that we might not always be able to lead them, but if we could generate data and hopefully and update those NCCN guidelines, then I think that's perfectly fine. So the piggyback approach is one way. I'm missing a slide here. I did want to give out a shout out to the Global Society of Rare Genitourinary Tumors. I think we saw some great data recently in penile cancer, which is another rare disease that Talal El-Zarif presented at GU ASCO this year, where there was hundreds of patients with penile cancer that he gathered from around the globe. And now we finally have an idea of what the response rate is in penile cancer because of that amazing collaborative international effort. So I think that's another great example of how we can move the needle forward. So we have to collaborate. We have to collaborate with industry. And again, I am grateful for the work that we did with our trial. And I think that there is still kind of ways forward and ways to collaborate and improve outcomes for these patients. I think when we're doing small ISTs, we need to consider carefully, might seem obvious, but how is it going to lead the needle forward? Are we going to be able to update the NCCN? Are we going to be able to do larger trials? And what are we really learning from small ISTs? We have a lot of large industry-sponsored trials out there. These patients should be studied. We have some important data coming in terms of ICONIC and SWOG 1609. And for our patients with pure squamous and pure adeno, there's really no known role for immunotherapy in these patients. These are major unmet needs. These are typically young patients. We really need to urgently move the bar forward there. In terms of a target-based tumor-agnostic approach, that might be advantageous. As I mentioned, the DLL3 example. We need more science and we need more collaboration always to move the bar forward. I love the GSGRT. I'd love to be a member of that club if you'll have me. And I think that there is kind of hope for the future and moving the needle forward. Thank you so much for your attention, everybody.
Great, fantastic talk. And you're absolutely invited to be part of our group moving this forward, because you've done a lot of thinking about how to move this disease space forward, Sam. So, I wanted to kind of open it up again for some time for discussion. One of the questions that I had, Sam and Rafee, for you both, and also for Andrea, you may be able to speak to this. How do we get it done? I know it's going to be a loaded question too. But obviously in the kidney cancer setting, they went to industry. I don't know how they got industry to get interested in their concept, because I've talked to industry about even like genomically sequencing a lot of tumors, and they show absolutely no interest whatsoever. So how do you engage industry to better run these studies? And then just from the design standpoint, since Hikmat and Francesca have told us that there's no targets for these specific subtypes. So how do we actually tell what type of therapy to use for some of these? Do you basket them all in one trial, go through different sequential treatments? How do you do it?
So I'll just comment to that. It is difficult to get industry interested in these studies. I have met with them many times about the Iconic and about other trials, and they are willing to support investigator-initiated trials, but not so much themselves run these small studies because they have other priorities, and it's all about their priorities. One thing I'll mention, because I think it's important, is I had a miscellaneous rare tumor cohort because we had 12 cohorts, and you just can't cover all of the rare tumors that there are, and I wanted to be as inclusive as possible. And although I thought this was, such a great way to include a lot of patients, it's really hard to interpret the data because in the end, we ended up with, I think, everybody wanted to enroll in the miscellaneous because they were all, kind of this esoteric cell type that wasn't classified. And it's hard to say, okay, well, maybe we should expand it. It's one patient. And so I think there's pros and cons to that, but, I found it that it's difficult to interpret. So unfortunately, we have to pick the more common rares, which I know sounds kind of, like an oxymoron, but I think in order to kind of move the needle forward, and we've been trying to, because of their rare, we try to be inclusive, but then we're not able to interpret the data. Kind of, exactly what happened with your study. You wanted to kind of group it, but then you just don't get a lot of these. And I think cooperative groups are great for doing this, although it just takes a long time to open a cooperative group study. Doing it yourself, within your institute and having several collaborators is good too, but then I feel like you're also kind of missing a lot of other potential patients that are out there. It is hard to cast a wide net. So I think it's really challenging, and I think groups like the society group, the Global Society Group of Rare GU Tumors is so important, so we can kind of develop this network and we all know of these trials, so we can refer and we can accrue and we can learn.
Yeah, I think, Andrea, that's a great, I don't really have all that much to add. I think it's challenging when approaching industry partners here. I think it's all about answering a question. For our patients with that metastatic adenocarcinoma, does immune checkpoint blockade work? And I think, really looking forward to the Iconic data and kind of and trying to answer that question. So I think if you could kind of go specifically, I think we just need to see the data that's out there and hopefully move the needle forward here. Because if we're doing lots of small ISTs, I think if we could somehow pool our efforts and accrue a large number of patients and and power studies appropriately, then that's how we move the needle forward.
I just have a quick question. So, this has been a great panel. I'm sorry I had to step out during Sam and part of Rafee's talk as well. But so as basic and translational scientists, what we try to do is figure out the mechanisms that lead to these subtypes. We call them subtypes now, not variants. So we've spent a lot of time thinking about the squamous component, right? But I think this panel's inspired me a little bit in some of my conversations with Hekmat, I think, over the years too. So if we were to think about the next variant to really focus on, right? There's lots of things to think about. Is it present in metastatic disease? Yes or no? How rare? Is it more common of the rares, or what should we focus on? Like, what should be the next thing? Is it like I'm feeling like sarcomatoid today? But is there we have a panel of medical oncologists, urologists, our esteemed pathologists. What do you guys think?
I think we should go after what's most common and kind of start there. What's affecting the greatest number of our patients, and I think our pathologists can help with that. And I think like I said, there is data out there on how these subtypes actually do from large trials. If we could just somehow collect that data and look at it, even if it is retrospective, that's better than nothing, which is what we have now. I'll just add that I also think this target-based approach, the DLL3 example being one, where if there's a promising therapeutic target, then we should run with that, even if it's an add-on to another disease, even if it's an add-on to a trial that's really geared toward another disease. If there's a promising target, then we should generate that data. And I think if our industry partners see that there are responses, then they'll run with that.
I mean, to answer the question simply, whatever variant or subtype that you have access to and good material, you gotta work on that one, because all of them are important. We don't know much about pretty much any one of them, so there's need on all of them to do something. And if you have access to a unique cohort, clinical colleagues, pathology colleagues, that's what you gotta go after. Any additional piece of information and knowledge is very important, going to inform us in dealing with the other subtypes.
Yeah, this is a great session, and one of the reasons it's such a great session is because it's so interdisciplinary. I wanted to make two comments. From a surgeon's perspective, the thing I always get nervous about with a trial that's neoadjuvant is that the therapy you're choosing is not going to work, and my patient's going to progress, and 4 months have gone by, and man, I might have had a resectable disease that because I put this patient on a trial, it's not resectable. So I think there were some assumptions made that neoadjuvant therapy is the right approach for some of these variants, as opposed to maybe an adjuvant approach. And I wanted to hear your thoughts on that and whether it varies by subtype, not to throw another variable in the mix. But then there's sort of this broader question that's also interesting, which is how do you negotiate IITs in a perioperative setting? I think Jeannie Hoffman-Sensis, who just left, but I will plug her trial with small cell, because the way that was negotiated is essentially patients can get their systemic therapy at Hopkins, but the surgeon can be in any of the 10 states that surround us as a way to try to negotiate that tension. And I think we're going to need to be creative in that way. And then, I can't see a patient with a variant histology and say what surrounding 5 states is there a trial with this variant. It has to be under one roof. And so I do think cooperative groups with some type of basket design where we have an answer for 5 to 7 variants is going to be the way to actually do this. And it'll take 8 to 10 years. So would love your thoughts on that.
Yeah, thanks, Max, for the question. Just take your first question in terms of neoadjuvant versus adjuvant. I think the typical paradigm for a lot of these variants, when we think about particularly the pure squamous and the pure adenos, is that neoadjuvant therapy, as Rafee said, typically doesn't. We don't pursue that path, and we do go straight to surgery. And so I think, in the perioperative space with the variants, potentially looking at that adjuvant space. But adjuvant trials, the problem with adjuvant trials is it takes a long time to accrue and to get your answer. Whereas with the neoadjuvant trials, you kind of have at least a path CR, a path downstaging endpoint. So, I think that adjuvant may be the way to go, but it's harder to do the trials. It is a multidisciplinary panel. We are missing our radiation oncology colleagues, from the panel, but it might be interesting to see, how does radiation play a role in a lot of these variants, particularly sometimes we do see HPV-driven squamous or HPV-driven tumors, and should those be treated more with a chemo-RT approach? And then in terms of your other point about being creative about trials, absolutely. I think there's this concept of decentralized trials. We have to be creative in terms of thinking about how to accrue to these trials, and to capture as many patients as possible.
Yeah, as a small comment, yeah. So I think, one of the surrogate, markers we need to capture is, time to cystectomy. So these small, independent trials, seeing, if we're actually delaying the time to surgery. So I think that'll hopefully help, address that question. And yeah, I think co-op group studies are the best, way to go. Basket trials focusing on, maybe the aggressive subtypes. I think that's the best way we can get, a large, multi-institutional, collaborative, effort to go forward. But from what I hear, it's hard. So.
Just a quick comment also on, sorry if so one thing, and I may sound a little radical, but I just don't, it's a bad peeve also. I don't know why we insist on making the variant histology dominant or non-dominant or give any percentage, because it's not like we have a good basis for why we choose 10, 20, 30, 50%. That's one thing. And second, it's not like our target is actually after the variant histology. We're giving global drugs that we don't know what they're targeting and what they're treating. So why is like the 30%, 40% of small cell plasmacytoid micropapillary, is it worse theory than the 50% or like the 10% or the 50%? Are we looking at the entire tumor? We're looking at UR. Maybe we took the part that has mostly the micropapillary, but the rest of the tumor is not micropapillary. And if you looked at a different section or a different surgeon gave you another UR, you're putting the patient in a different category. So I don't know if there's a role, like as physicians, try to kind of change that mindset. Why is it predominant urothelial? Why is it a unique variant histology? Otherwise, I mean, unless we treated these patients, we will not know if they really respond or they don't respond. But we just left them out for the most part. And again, our treatments are not targeting these variant histologies or the urothelial component, and we don't know it. So I think it will be great if we can kind of push back in the industry that this criterion has like no basis, no scientific basis. Unless we do the work, we will not know. And hopefully that might change.
Last question.
Oh, I have a few. This is an amazing panel. Just absolutely wonderful. Thanks for putting this together. This is really fun to be in the audience. I have a couple of thoughts. First of all, Sam, thank you for putting that slide up. I mean, there's a lot of junior people in the room. It's hard to develop these studies. So for you to be brave enough and say, this is what we wanted and this is what we got. I've never seen a slide like that. It's really important. Thank you for talking about the small cell study. It took 7 years and discussions with 4 companies to open that trial. And it's a turtle, but I'm trying. So thank you very much. I mean, we're all trying. I think we've all kind of been down the same path of, asking for what we know is really important and not getting it. And I think it's time for all the people in this room to start having different conversations. The FDA should mandate that if a drug company wants to, do work in this space, they also need to pay attention to the people with the biggest unmet need. And there's a lot of people in this room. This is an advocacy meeting. I mean, it would be great to have the advocates kind of come with us and talk about all the patients that are left behind. We have all these great new drugs and all this great, survival, but we don't know how these great new drugs work. And importantly, in some of these variant subtypes, there are patients, more patients in the squamous, subtype. There's more African-American patients in that subtype than all the others. So really a huge unmet need that we are not paying attention to. So thank you for talking about variant histology. We have so much work to do. Finally, from an industry perspective, if you have a drug that's not FDA approved, then we have spaces where there is no standard of care. That's really important. So maybe the industry partners can start paying attention to these spaces as a real unmet need so we can get drugs approved. This is awesome, guys. Thank you.
All right, so thank you so much for that impassioned statement. I definitely second your opinion. So last but not least, I want to turn the floor over to my co-chair, Karima, Oualla, who actually came all the way from Morocco. So she's an assistant professor at Hassan University in Morocco, associate professor, I apologize. And she will be giving us a global perspective on what variant histology looks like, mostly in Africa. So really, really looking forward to your talk, Karima.
Thank you, Roger, for this kind introduction. It's really a pleasure for me to be with you today. Coming a long way from Africa, from Morocco. And when I was asked to talk about this general perspective, first thing I did, I sent an email to Roger. What are you waiting for me to talk about after all what has been said? So from pathology, genomics, clinical trials. So we try to cover some points that maybe are not always discussed in the guidelines, which are the disparities in access to diagnosis, to treatment. It's very exciting to see all these advances in terms of genomics, of defining targets, targets, etc., big advances in drugs trial, but also we should not forget that in some parts of the world, this is not the priority. The priority is to eradicate some endemic infection that are major risk factor behind this cancer, but also to have some democracy in terms of access to diagnosis, to treatment. But also I will not only talk about the specificities from Africa, but I will also highlight the management of those variants from the perspective of med oncologists. So, this introduction has already been said by all panelists. So there is no optimal systemic therapy for those variant bladder cancer given the rarity of this disease. And we are happy to see all the advances in comprehension of genomic profiling of those variants that will allow to define targets that can be actionable, like what we see in the other common or conventional cancers. And I think that there is a huge need of collaboration. So in order to have strong data coming from trials, because we still have data coming only from case series, databases, expert opinions, and some small single arms. So since I will be talking about specificities in Africa, so here is a study, a meta-analysis including 22 studies carried out across 15 African countries with the objective to determine the incidence of bladder cancer in Africa. And we can see here that the pooled incidence was estimated to be 7 per 100,000 population in men and 1.8 for women. So it's predominant for male cancer also in Africa. But we can also have that in Africa, we have disparities across the same continent. So we have a higher incidence when we move to Egypt, for example, Tunisia, Libya. Well, for my country, Morocco, bladder cancer, it's not that a huge public health problem like it is in Egypt or some sub-Saharan countries like Tanzania and others where we have endemic infection that is behind the high incidence of bladder cancer. So this is the statistics of Morocco from Global Can. So you can see that for male population, it's the fourth one. But when we move to Egypt, it's really a huge public health problem. So for both genders, it's the third one behind hepatocellular carcinoma, also due to a viral infection that is very common in Egypt, and then breast. And when we move to male patients, so it's the second one after liver cancer. So it's not prostate, it's not lung, but it's not hepatocellular carcinoma and bladder and the second rank. So here also you can see that for the histology, we see clearly that the squamous cell carcinoma is the predominant subtype in Africa, with this strong link I mentioned with the bilharzia infection. And you can see that from country to country there is a difference, but we have between 30 and 70% of histology that is attributed to squamous cell carcinoma. So this is the predominant subtype that we have in the continent. So when we move to the management of bladder cancer in those different countries, so we can see first of all that I think the thing that stopped me first is, the rate of advanced disease, which is huge. So we have more advanced T stage, more node involvement, more metastatic stages, and 27% of cases are inoperable given this, based on this advanced stage. So this is make prognosis poorer. And we have also tried to understand or to see how is the sensitivity to treatment in those countries. We have different references here, and we have reported some radio resistance and chemo resistance for this squamous cell carcinoma compared to the common urothelial carcinoma. So I think one first key message from Africa that we have a growing incidence. Fortunately, we have now more and more eradication of the infection, so especially in Egypt, where we have this decline in terms of bladder cancer incidence, but we still don't have accurate statistics to confirm this. Also, we need really accurate data, accurate sources, and the collection of data from all, so because we don't have really accurate data about the statistics in Africa. So another point, since we are talking about disparities, I thought to put this slide that was presented in last ASCO GU 2023, and it shows simply the cost of bladder cancer. And you can see here that the cost is really high, and even it's keeping getting higher over time. So when we made the projection on 2030, it will reach around $12 billion. So it's a costly cancer, and this cost also becomes higher when we have more complications, so for treatment, either surgery or medical treatment. And this cost also is becoming much higher when we move from localized disease to regional disease to metastatic disease. Why I mentioned this particularity of the cost of bladder cancer, just to let you know that, yeah, we are happy to see those genomics and those drugs in the ongoing trials, but also this cost is really a barrier for many countries, talking about Africa, to have access to correct health care for bladder cancer, but also for all the other cancers. So, well, let's move to the variants and the highlights and the management and some particularities. And I will start with squamous cell carcinoma, that I have mentioned is the most frequent subtype in Africa. And the management for sure for localized disease for early stages is based on cystectomy. We had local recurrence that is common and which is responsible to poor survival. And so there is no proven role of chemotherapy in the early stage, so for the neoadjuvant and adjuvant, but we have more radiosensitivity that was reported in the Egyptian series, so where they compared, for example, in this study, the radiotherapy in the post-operative setting compared to cystectomy alone. And you can see here that the 5-year disease-free survival was improved with the use of post-operative radiotherapy with 41% versus 25% for cystectomy alone. Also, in this other Egyptian study, we have tested this post-operative radiotherapy in the squamous cell, bilharzial squamous cell bladder cancer, and we have reported again that there is improvement of survival with the use of post-operative radiotherapy. And between brackets, in this study also they tested the role of mesonidazole in the adjuvant setting, but they didn't seem to add any gain in terms of survival. So what about the advanced disease for the squamous cell carcinoma? So we have this prospective trial evaluating the phosphamide, paclitaxel, and cisplatin for the advanced non-transitional cell carcinoma, mainly growing from the epithelial component, so the squamous cell adenocarcinoma and small cell carcinoma. And it has shown that this protocol or this regimen is active in this disease and may be suggested for patients. For the other epithelial variant, the adenocarcinoma, so we know that, so it has been already discussed that we should always look if it's the pure or it's just a differentiation, so from urothelial carcinoma, urachal, non-urachal. So with this urachal adenocarcinoma that has the specificity of younger onset, it can be the median overall survival from the MD Anderson Cancer Center is around 46 months. And when we look at the genomic landscape of the adenocarcinoma, and I think it was already mentioned in previous talks, so we had this particularity of having some KRAS mutations, so the PIK3 and the TP53. And with this similarity, sometimes with the enteric cancer or colon cancer, we find that we tend to use, and this is from Andrea, present with us here, so showing the chemotherapy options for the patients with adenocarcinoma that can include the 5-FU based on the similarity with the colon cancer with some modest response or modest outcomes. We can also even use some biologics like the anti-EGFR based on the KRAS status or the bevacizumab. Otherwise, so we have the other option of paclitaxel, platinum, phosphamide regimens. So for the urethral adenocarcinoma, so just to mention that surgery is the basis or the backbone of treatment. So we have this possibility of partial cystectomy that with no difference in terms of survival versus radical cystectomy. There is no strong evidence to support neoadjuvant or adjuvant therapy for this subtype. And regarding the multimodality approach, so we have this this study that have shown that plus we have localized disease, negative margin, negative lymph node, and the resection of the ligament. So we have improved overall, improved survival for those patients. So same here. So we can see that for the non-urethral adenocarcinoma, the multimodal approach based on surgery and radiotherapy is better than radiotherapy alone. Well, micropapillary arterial carcinoma, a lot has been said by our pathologists. So it's associated with poor prognosis, aggressive course of the disease, and this particularity of HER2 overexpression and amplification. And in this study from the MD Anderson, again, with our friend Ashish, who is not unfortunately with us, so they have underlined that it's associated with poorer prognosis, with more advanced disease. 44% have T2 or more, and a quarter of patients are node positive. And we have seen that the overall survival was similar if we are in non-muscle invasive or muscle invasive, but we also underlined from this study something very important is that this subtype is not responsive to the intravesical immunotherapy, the BCG therapy. So maybe those patients should be offered cystectomy, early cystectomy. Also here regarding always the micropapillary bladder cancer. So we can see that when we give the neoadjuvant chemotherapy, so we improve the rate of pathological response and complete pathological response, with here around 45% who became PT0, which confirm the necessity to include those patients in the approach of neoadjuvant chemotherapy followed by surgery. So the HER2 pathway, it has been discussed, and we have data coming from this phase 1 trial. So with the trastuzumab deruxtecan, this EDC that you know is now very famous in solid tumors and oncology, with the spectacular results in breast cancer, but not only, also in lung cancer and even in digestive cancers. And here we have seen that there is promising also results in urothelial carcinoma with near 77% of disease control, which is very exciting. So small cell bladder cancer, very aggressive. We know it's a highly proliferative disease, and in general, so with more node positive, more metastatic disease, shorter survival. We know that it's highly proliferative, but also it's highly responsive to treatment, so to chemotherapy based on cisplatinum. That's why also those patients should be treated in a multi-modality approach with chemotherapy or radiochemotherapy in the neoadjuvant setting, so followed by cystectomy. And here I just bring you this slide from the ASCO-GU 2023 comparing the neuroendocrine carcinoma and non-endocrine carcinoma of bladder cancers. And we have seen that despite that we have more advanced stages, so we have similar outcomes between the two groups, and this is real world data confirming the need of treating adequately those patients as early as possible. So here again in the small, this is phase 2 clinical trial of the neoadjuvant chemotherapy with efosfamide, doxorubicin, and etoposide cisplatin in the small cell urothelial cancer. And you see here also that it plays a major role in the neoadjuvant setting. It can improve the outcome of patients, but we can say that for the metastatic setting, the prognostic is really poor. But also we have seen that there is some predilection for the spectrum of metastasis for those small cell cancers. So that's why it's mandatory to go in the workup for the brain imaging, since we have this tropism to brain metastasis. Well, here just short message for the sarcomatoid versus the classic urothelial carcinoma. This is This is a paper that shown, that was presented in last ASCO and showed that it has poor prognosis, and perioperative chemotherapy with surgery was associated with improved survival outcomes compared to surgery alone. So I think if we have a message to keep in mind after all what we saw is that all those cancers, like the conventional urothelial carcinoma, should always be taken in a multidisciplinary approach. No one can treat a patient alone, so it's always mandatory to have the point of view from the pathology, the genomics, and also discuss all those parameters with the surgeon and oncologist, radiotherapist for better care for our patients. Well, for immunotherapy, we have seen that there are a lot of ongoing trials. We have some data coming from the trials presented in previous talk, and here it's just a French multicenter retrospective study taking patients with non-urothelial bladder cancer, and we try to see the response and the outcome for those patients who received chemotherapy or immunotherapy. We can see that the rate of overall response is much more important with chemotherapy reaching 66% versus 22% for immunotherapy, but I remind you that it's only about 9 patients, so a lot of work also should be done in terms of including a lot of patients in clinical trials, and this cannot be achieved without an international effort in order to overcome this rarity of the disease. So my final thought is, as we all concluded, that there is no well-established guidelines for the treatment of those rare variants, but I think the main message again is an international collaboration for this rare entity in order to and I want also to underline to not forget other parts of the world when we do clinical trials, but because this is the best way, to have the real image of what is happening for bladder cancer, and particularly the rare variants that are present not only in Europe, Asia, or America, but also in Africa and other parts of the world. And this international effort cannot be achieved without, societies that think about these rare entities. And here again, I remind you about the role of Global Society of Rare GE Tumors. I have the honor to be a council member in this society, and we have subcommittees by organ site, but also by pathology, and the main focus is to raise those challenges and try to find solutions through international collaboration. And this collaboration has been also more reinforced with this collaboration with the International Bladder Cancer Group, and I wish once again that we can achieve with those international collaborations more comprehensive for the situation in all over the world, and try to have better outcomes for patients in every part of the world. And thank you.
Great. All right. I think, in the interest of time, I'd like to thank everyone for attending. It's really been a great session. I think this session highlights the difficulty of moving this disease space forward and really understanding what the biology of the disease is, what the targets of therapy may be, and also how we can bring about everybody so that we can, get trials going in this disease space. So thank you very much. Have a great rest of the meeting, and safe travels back.